Hello, I'm Dr. Laura Pinault, Program Director at University of Kentucky, and I am recording a Malignant Hyperthermia keyword review for the Anesthesiology content outline. This slide shows the American Board of Anesthesiology keywords for malignant hyperthermia based on the most updated keyword content outline from 2024. MH is obviously an important and unique disease to the field of perioperative medicine and anesthesiology, and my hope is that you can gain a deeper understanding of the pathophysiology, risk factors, treatment, and prevention of this disease. The Malignant Hyperthermia Association of the United States, or MHOUSE for short, is our dedicated national professional association that provides education, support, and clinical recommendations for the care of MH patients. Should you ever have a clinical event that is suspicious for MH, calling the 24-hour hotline is never the wrong answer. Emergent scenarios are also excellent times to utilize cognitive aids for management, such as the Stanford Anesthesia Group's Cognitive Aid Program Emergency Manual, which is widely available at many academic centers, hopefully at yours. This is a deadly disease if it's unrecognized or left untreated, so prompt action is required. The MH syndrome was first described in 1960 by Denborough and Lovell, two physician scientists. It is an inherited clinical syndrome that is characterized by elevated core temperature, tachycardia, tachypnea, hypercarbia, rigidity, acidosis, and hyperkalemia. The underlying cellular abnormality lies within the skeletal muscle cells, leading to activation of muscle contractile elements and hypermetabolism, hence the catabolic symptoms of rigidity and heat. Please note the temperature can rise quite rapidly, up to 1 degree Celsius every 5 minutes, and masseter muscle spasm is a relatively specific sign or should pique your interest in MH as a possible diagnosis. So we'll just do a basic science anatomy review of a muscle fiber, also known as a sarcomere. A sarcomere is an organized grouping of myofibrils that are composed of thick and thin filaments, actin and myosin, that are organized in a long axis surrounded by mitochondria, sarcolemma, and nuclei. The sarcoplasmic reticulum is a webbed network that surrounds each myofibril and serves as a calcium reserve that releases calcium when the muscle fiber is stimulated to contract and reuptakes calcium when the muscle fiber relaxes. Now we'll review normal skeletal muscle contraction. A myelinated motor nerve carries an action potential that arrives at the neuromuscular junction, which is a nicotinic acetylcholine receptor, and acetylcholine is released, binding to the nicotinic receptors. Sodium channels open, and an excitatory coupling propagates the action potential down the T-tubules of the sarcomeres. A protein called the dihydropyridine, or DHPR receptor, senses the membrane potential on the T-tubule membrane and relays this to another protein, the ryanodine receptor, on the sarcoplasmic reticulum membrane inside the fiber. The dihydropyridine receptor consists of 5 subunits, one of which forms a calcium channel. The ryanodine receptor releases the calcium stored in the sarcoplasmic reticulum to the sarcolemma. A calcium pump normally restores the calcium back into the sarcoplasmic reticulum once the myofilament binding relaxes via an ATPase-dependent mechanism. In MH, the dysfunction lies with the ryanodine receptor. A mutated ryanodine receptor remains locked open, leading to the uncontrolled release of calcium with elevation of cytoplasmic calcium levels and continuous muscle activation, as well as ATP breakdown. Muscles can't relax. The sarcoplasmic reticulum cannot resequester calcium, and the relaxation patterns cannot take place. The consumption of ATP stores exhausts the mitochondrial oxidative phosphorylation pathway, and anaerobic metabolism becomes predominant, bypassing the Krebs cycle and producing lactic acidosis and glycogenolysis. Eventually, the sarcolemic integrity breaks down and potassium begins to leak extracellularly. So I'd like to discuss the pharmacogenetics of malignant hyperthermia. It is inherited in an autosomal dominant pattern with reduced penetrance and variable expression. It is a spectrum of diseases. There are ryanodine receptors in skeletal muscle, the RYR1 protein, and cardiac muscle, RYR2 proteins, with RYR1 being most commonly associated with malignant hyperthermia. More than 200 RYR1 variants that co-segregate with malignant hyperthermia and/or calcium channel dysfunction have been reported to date. This includes also mutations of the dihydropyridine receptors, calsequestrin proteins, and the sarcoplasmic reticulum ATPases. The exact incidence of malignant hyperthermia is unknown. The incidence varies depending on the concentration of MH families in a given geographic area. High incidence areas in the United States include the upper Midwest, such as Wisconsin, Nebraska, West Virginia, and Michigan. However, the prevalence of genetic changes that predispose to malignant hyperthermia are much higher. About 1 in 2,000 patients harbor a genetic change that makes them susceptible to MH, but that does not mean that they will necessarily express the disease.
So as anesthesiologists, what do we absolutely need to know about anesthetic triggers of malignant hyperthermia in the perioperative period? Well, we know that all of our fluorinated, halogenated, volatile anesthetics, including desflurane, sevoflurane, isoflurane, and halothane, are known triggers of this abnormal calcium regulation within the mutated ryanodine receptors and should absolutely be avoided, as well as our only clinically active depolarizing neuromuscular blocking agent, succinylcholine, which triggers the same pathophysiology. So in any instance of suspected or history of an MH, we must absolutely avoid and do a non-triggering anesthetic. However, all of our other conventional anesthetics are considered safe to use and have never been proven to trigger MH. This includes nitrous oxide, intravenous anesthetics, local anesthetics, non-depolarizing muscle relaxants, opioids, and other typical adjunctive medications given in the perioperative period. Please also note that malignant hyperthermia in a genetically susceptible patient can be triggered by extreme physiologic stress, such as very intense exercise or heat exhaustion, not only medication exposures.
The treatment for malignant hyperthermia is a medicine called dantrolene. Dantrolene is a hydantoin derivative, and it directly interferes with muscle contraction, decreasing calcium in the muscle cells. It is the only skeletal muscle relaxant that acts peripherally at the sarcolemma. Others act centrally. Dantrolene does not block neuromuscular transmission nor interfere with the reversal of muscle relaxants. Although it does not block the neuromuscular transmission or the action potential, the mechanical response to nerve stimulation will be depressed, with subsequent potentiation of non-depolarizing muscle blockade that is given. So when you use dantrolene with other non-depolarizing muscle relaxants, you need to take care to ensure that the muscle strength has returned prior to extubation. Dantrolene may cause significant muscle weakness in patients with pre-existing muscle disease and should be used with extreme caution in those patients. And another known side effect of giving dantrolene is sterile phlebitis that may follow the administration, so you should infuse it through the largest possible vein, and if you get phlebitis, treat it with warm soaks and elevation. You should not use dantrolene in co-administration with calcium channel blockers such as verapamil or diltiazem, because you may produce a life-threatening hyperkalemia and myocardial depression. Otherwise, there does not appear to be significant negative interaction with other drugs. I want to talk about dantrolene versus Ryanodex, which is the newer formulation of dantrolene. It's still the same medication, but the way the suspension is formulated makes it much easier to reconstitute. Traditional dantrolene requires large volumes of sterile water and comes in smaller dose vials. It can take more than 15 to 20 minutes to reconstitute an appropriate dose, which is not favorable in an emergent situation. Ryanodex is dantrolene sodium in a lyophilized powder that can be reconstituted within 1 minute with sterile water per the pharmaceutical instructions. The initial dose given should be 2.5 milligrams per kilogram, but you can keep repeating doses until clinical syndrome subsides. Some case reports have given 10 to 20 milligram per kilogram of dantrolene in total. The treatment is otherwise supportive. Hyperventilation, treatment of acidosis and hyperkalemia, actively cooling the patient with ice cold fluids, coolers, and other fluids loading to maintain urinary output.
Certain diseases are known to be associated with malignant hyperthermia, whether it be the susceptibility to full-blown syndrome or a non-MH associated rhabdomyolysis summarized on the slide below. Any patient with myotonia or a muscular dystrophy on the spectrum of diseases should trigger in your mind a susceptibility to full-blown MH syndrome, the diseases in the left column, or at least the potential of rhabdomyolysis with exposure to succinylcholine with diseases in the right column, or questionably after exposure to volatile anesthetic agents. I'll read a quote from the article below. Some myopathic conditions have been associated with the development of fatal or life-threatening rhabdomyolysis upon exposure to volatile anesthetic agents or succinylcholine. The most common of these conditions are Duchenne and Becker muscular dystrophy. Although rhabdomyolysis with hyperkalemia can be a feature of MH, the MH syndrome usually manifests signs of hypermetabolism, such as respiratory acidosis, metabolic acidosis, and excessive heat production. The development of life-threatening rhabdomyolysis with hyperkalemia after administration of succinylcholine to patients with Duchenne or Becker muscular dystrophy is well documented, and therefore succinylcholine is contraindicated in patients with these disorders or other conditions with acute or progressive muscle atrophy, such as acute burns or stroke victims. The use of volatile anesthetics without succinylcholine have been reported to cause non-MH related rhabdomyolysis and hyperkalemia in patients with these dystrophies in a few selected case reports. So when you suspect MH in your patient, what should you do? Well, the first thing you should do is call for help and notify the MHouse Association, if in the United States, and get an MH cart with dantrolene, and ideally a cognitive aid to help you delineate the steps in the process. These steps are broadly defined below. You should immediately discontinue any exposure to triggering agents and convert to a non-triggering total intravenous anesthetic. You should change out your breathing circuit in CO2 absorbent and attach charcoal filters to the new breathing circuit. You should administer 100% oxygen and hyperventilate your patient to reduce respiratory acidosis and give dantrolene as soon as it can be reconstituted. Treatment is otherwise supportive by checking arterial blood gases and treating the metabolic acidosis and the hyperkalemia that might ensue, and actively cooling the patient through a variety of methods. The patient should be monitored for recrudescence of this syndrome over the next 24 to 48 hours in the intensive care unit. And remember, the dantrolene will cause muscle weakness, so it is advisable to keep the patient on mechanical ventilation until assurance that the syndrome is passed and dantrolene administration has ceased. I wanted to talk just a little bit about what activated charcoal is so that we understand that. Activated charcoal is a carbon purified from wood and other organic sources, which has been treated to create an extremely porous structure. It is treated either chemically by the addition of a strong acid or base, followed by heat treatment, or physically by heating the charcoal in an inert gas such as nitrogen or argon, and then exposing it to oxygen to create a porous state. The highly porous structure creates a huge surface area of exposed carbon atoms that are readily available to bond to any organic matter that passes over them. Hence, when volatile anesthetic agents pass through the activated charcoal, they bind to these exposed carbon atoms and are held within the charcoal through the process of adsorption. So what should you do to prevent MH? We know that prevention is almost always better than a cure. First, do you need a general anesthetic? Could you do a regional anesthetic, a neuraxial anesthetic, or even a sedation for this case? If you need general anesthesia, you should plan a non-triggering total intravenous anesthetic with machine prep. Machine manufacturers will vary with their flushing instructions and duration, but the MHouse recommendation is that anesthesia machines will still need to be flushed with high fresh gas flows, greater than 10 liters per minute, for 90 seconds prior to placing the activated charcoal filters on both the inspiratory and expiratory limbs. These filters are effective in keeping gas concentration below 5 parts per million for up to 12 hours with fresh gas flows of at least 3 liters per minute. Prophylactic dantrolene is not recommended. As clinicians, we should always have a differential diagnosis in mind for any suspected syndrome. then malignant hyperthermia syndrome has some overlap with other clinical syndromes that could mimic this disease. They can all present with hyperthermic conditions as their unifying effect. Neuroleptic malignant syndrome is also a hypermetabolic syndrome characterized by hyperthermia, rigidity, rhabdomyolysis, acidosis, and tachycardia. However, it is precipitated by the administration of neuroleptic drugs in a somewhat dose-dependent fashion, including typical and atypical antipsychotics and phenothiazines. The basic pathophysiology is that they all cause centrodopamine depletion, and the treatment is giving benzodiazepines and dopamine agonists such as bromocriptine, but dantrolene can also have some efficacy here. Serotonin syndrome is a hyperthermic condition triggered by exposure to serotonergic agonist drugs such as tricyclic antidepressants, monoamine oxidase inhibitors, and serotonin reuptake inhibitors, and can be triggered with exposure to other perioperative medications that we commonly use. For example, opioids like fentanyl, tramadol, meperidine, and methadone, metoclopramide, and serotonergic agonists for post-op nausea vomiting treatment or prophylaxis. The treatment of serotonin syndrome is supportive in giving a medicine called cyproheptadine, which reduces the systemic effects of serotonin. Thyroid storm is a severe sympathetic surge from uncontrolled hyperthyroidism. The treatment is supportive and includes antithyroid medications such as propylthiouracil, iodinated contrast agent, and steroids. Patients with malignant hyperthermia need follow-up. They should be advised to obtain a medical alert ban, and a medical record alert should be placed in their chart. You should consider referral for testing, either the caffeine halothane contracture test or genetic testing, and the patient should be registered with mHouse if the case occurs in the United States. The caffeine halothane contracture test is an invasive muscle biopsy test and is only offered at a select number of centers in North America. It is highly sensitive, close to 100% for the diagnosis of MH, and remains the gold standard. There is a certain false positive rate of around 20%, but if it is positive, it means that almost certainly this patient has this disease. Both caffeine and halothane are ryanodine receptor agonists. When susceptible muscle is exposed to these triggers in a laboratory setting, an abnormal pattern of muscle contraction is produced. This test is not recommended for young children less than 10 years old. Genetic testing, by contrast, is non-invasive but has much lower sensitivity. However, the results are more specific, and thus a lower rate of false negatives occurs. Currently, more than 30 mutations can be reliably identified by genetic testing. I hope you found this malignant hyperthermia keyword review to be a useful study aid. Malignant hyperthermia is a perioperative emergency that requires a coordinated team response for a successful outcome. I encourage you to review textbooks and make notes on this disease. Thank you for listening.